Good day. This is our lecture on how to critically appraise literature. To practice medicine, it needs to be evidence-based. Critical appraisal of an article will give evidence needed for your practice. But for young doctors, it would need practice. Young doctors should learn appraising journals without apprehension to analyze published data to test its trustworthiness, and you have to train yourselves for that. Outline of this lecture would cover an introduction to critical appraisal, define, differentiate, strengths and weaknesses of systematic reviews and meta-analysis, sources of systematic reviews and meta-analysis, levels of evidence, interpretation of basic statistics in meta-analysis, confidence intervals, and forest plots, critical appraisal of systematic reviews and meta-analysis. So it is the process of systematically examining research evidence to assess its validity, results, and relevance before using it to make a clinical decision. So what is it not? It's not a negative dismissal of any piece of research. It does not just assess the results, and it's not based entirely on statistical analysis, and it's not undertaken by experts only. Why do we need to do critical appraisal? We have to find out if the study is valid, are the methods robust, to find out if the study is reliable, what the results are, and are they credible, and to find out if your study is applicable. Is it important enough to change my practice? So the advantages and disadvantages of critical appraisal are the following. Advantages would be systematic way of assessing again validity, results, and usefulness of research. Contribute to improve the quality of practice. It is an objective assessment of information, and it's not difficult to develop skills. Disadvantages, it's time consuming, not always providing easy answers, and dispiriting if you lack good evidence. But you can all do it with the right tools and guidance. So what do we need to know for us to critically appraise evidence or articles? You have to be aware of study designs, which we have learned in our previous lectures. Levels of evidence, again, have basic statistics, have checklists, and critical appraisal resources. So when should we do critical appraisal? So we conduct literature reviews for grant proposals whenever we have new projects. When we evaluate effectiveness, costs, and benefits of health programs intervention. When we establish innovations in the health program to set right implementing health policies and aid in public health decision making. And it aims to help people develop the necessary skills to make sense of scientific evidence based on, again, validity, results, and relevance. So it gathers data, collects data, and analyzes data to provide meaningful information. However, most research would not be good quality, and many studies, if we are not careful, are biased and results are untrue. So these may lead to false conclusions. Hence, we have to be critical in the evidence or journals that we use eventually for clinical practice. So this is an essential step in the process of putting research into practice. So you ask questions about an article's research methodology. You have to learn to be scrutinizing in how it collects its data and how it analyzes and interprets its conclusion. How its findings are presented will help you determine whether that article's conclusion should influence practical decision making. So, study design. So, again, this is a review on the different study designs that we have discussed. So, it has its own strengths and weaknesses. So, what is a systematic review? A review that has been prepared using some kind of systematic approach to minimize bias and random errors. Components of the approach will be documented in a materials and methods section. So it is a part of all the reviews and it summarizes all reviews that are valid. So why do we need to summarize or do systematic reviews? Sometimes we have information overload. Sometimes there will be publication bias. We have to eliminate poor quality of reviews. And sometimes there would be missing links in some reviews done. We have a variety of sources listed as the following. Most often we use Cochrane, Library, PubMed, evidence-based reviews journals that would be readily available in the internet. Format of systematic reviews would be the following. We formulate a review question. We define inclusion and exclusion criteria. We locate studies, select studies, assess the study quality, data extraction, analyze and present results, and we interpret results. So how do we formulate a review question? So is the question focused in terms of population studied, intervention, exposure given, and the outcome considered? For example, do anticoagulants prevent strokes in patients with atrial fibrillation? Is the population clear? Maybe we could have defined it better. Intervention. Anticoagulants could have been more specific. Outcomes considered, we have a specific disease entity in atrial fibrillation. Inclusion and exclusion criteria have to be defined. So were the right type of studies included to answer the question? And can you have observational studies such as cohort case control or diagnostic screening tests, prognostic or non-randomized trials? And studies should be defined according to their design, participant characteristics, interventions, and outcomes. And then we do a comprehensive search to locate the studies. We could use different databases, hand searching. We look for gray literature, even in foreign languages, and follow up your references. Make sure that there is also eliminated publication bias. There may be unpublished studies, and it has to be explicit. Then you select and assess the studies. The eligibility criteria for study selection can be applied. More than one reviewer can help reduce bias, and you have to have checklists and scoring systems. What will the findings mean? The effect measures, remember your odds ratios, relative risk, and mean difference. Remember your p-values, remember your confidence intervals, and this would mean significantly if your study is valid, reliable, and relevant. So the use of statistics assesses the weight of the evidence that a treatment works or does not. gives an estimate of the treatment effect, and you could test to see how likely it is that the effect would have been seen by chance. So, odds ratio expresses the odds of having an event compared with not having an event in two different groups. So, it is odds in the treated group over odds in the control. Having an odds ratio that is equal to 1 would mean that treatment has identical effect to control. Less than 1 means the event is less likely to happen than not, and greater than 1 means that the event is more likely to happen than not. Clinical trials typically look for treatments which reduce event rates and which have odds ratios of less than 1. The importance of defining the outcome. So we have the value of our odds ratio over our relative risk, less than 1, 1, and greater than 1. For adverse outcome, it means that your new intervention is better. If it's 1, new intervention, no better or worse. Or if it's greater than 1, new intervention is worse. And it's the opposite if your study is looking for a beneficial outcome. If it's less than 1, new intervention is worse. 1, new intervention is no better or worse. And greater than 1, new intervention is better. Your p-value measures of statistical significance which tells us the probability of an event occurring due to chance alone. Your p-value results range from 0 to 1. The closer your p-value is to 0, the less chance that there is that the effect of two interventions are the same. Results larger than the cutoff are considered likely to attribute the event to chance, while results smaller than the cutoff value are likely to have occurred because of a real explanation. So your p-value usually cutoff is 0.05. So less than 0.05 indicates the result is unlikely to be due to chance. Greater than 0.05 might have occurred by chance. Be careful. If your p-value in the non-significant range tells you that either there is no difference between the groups or there were too few subjects to demonstrate a difference, there is not much difference between 0.049 and 0.051. So p-values do not indicate the magnitude of the observed difference between treatments that is needed to determine clinical significance. Confidence interval is the range within which we have a measure of certainty that the true population value lies. Or it's around a result obtained from a study sample indicating range of values within there is a specific certainty that the true population value for that result lies. So what does confidence interval tell us? It tells us whether the result is significant or not. The width of the interval indicates precision. Wider intervals suggest less precision. So it could show whether the strength of the evidence is strong or weak. In general, it's pegged as 95%. 95% confidence interval is the range within which we are 95% certain that the true population value lies. How is it reported in ratios? The line of no effect centers around 1. So if your CI for a relative risk or odds ratio includes 1, then you are unable to demonstrate statistically significant difference between the two groups. So what is a meta-analysis? It is a statistical analysis of the results from independent studies which would generally aim to produce a single estimate of the treatment effect. So this is a forest plot. The label tells you what the comparisons and outcome of interest are. Scale measuring treatment, you take care when reading the labels though. So each study has an identified author, treatment effect sizes for each study. Horizontal lines are your confidence intervals and your diamond shape is the pooled effect of all studies. Horizontal width of diamond is your confidence interval. The vertical line in the middle is the line of no effect. For ratios, this is 1. For means, this is 0. So how do we interpret forest plots? So you look at the table of the forest plot, the intervention, outcome, effect measure of the investigation, and the scale. The names of the left are the authors of the primary studies included in the study. The small squares represent the results of the individual trial results. The size of each square represents the weight given to each study in the meta-analysis. The horizontal lines associated with each square represent the confidence interval associated with each result. The vertical line represents the line of no effect, and the pooled analysis is given a diamond shape. The horizontal width of the diamond is the confidence interval. What are the advantages of a systematic review or meta-analysis? It limits bias, it is objective, it gives good quality evidence, more reliable and accurate conclusions. It's added power by synthesizing individual study results, and you have control over the volume of literature. Disadvantages would be it could be done badly just the same as a journal or article could be done badly as well. So two systematic reviews on the same topic can have totally different conclusions. Sometimes there would be inappropriate aggregation of studies. So it's just as good as the papers that have already been done. So garbage in, garbage out. And it tends to look at broad questions that may not be immediately applicable to immediate patients. In conclusion, critical appraisal of systematic reviews and other research is well within your capabilities. So again, use a recognized checklist, update your literature searching skills regularly. So these are the checklists that we could use in critical appraisal that you could look up. So how do I critically appraise research? So be open to everything. Believe in papers from high quality journals so that you could read and decide for yourself. Let other people read and decide for you, or read for yourself and make a structured appraisal. So read the abstract firstly. Are your issues discussed there? What are the main findings of the research? Do you want to know more after reading the abstract? Does it address a related question? And there are the reasons to doubt findings without reading the whole article. Then read the introduction and discussion because they will help you identify key concepts, goals, subjects, and themes of the research. Then look at the methodology. It will give you a step-by-step description of exactly how the study was carried out. Where was the study done? Where was the data and how was data collected? Is it primary or secondary? Is the data good? And does the study adequately control difference between groups? Are your statistical methods appropriate and sample size is large enough? How good are the measures? Do the measures accurately reflect what the researcher was trying to measure? How clear and appropriate are these measures? Are they actual measures or proxy measures? Are the measures well established in either prior research or through pilot testing by the researcher, or they ad hoc? Then look at the discussion. It's more detailed and precise than the abstract and will explain to you limitations of the study and possible implications which are not mentioned in the abstract. Compare the raw data given in the tables with the results analyzed in the discussion and conclusions. Are the results reported in the conclusions consistent with what is reported in the tables? And is the interpretation consistent with what the actual findings were? How well are the results related to other research on the same topic? In the discussion or conclusions section, is there a review of how these results compare or contrast with prior research? If this report found something different from previous research, then it's important to question on appraising the reliability of the findings. So this is a guide of critical appraisal of an article on harm and risk. So first question, are the results of the study valid? So primary guides, was the exposure status clearly defined and measured? How was the outcome of interest measured? What was the follow-up time and was it adequate to measure the outcome of interest? Was the outcome measured in the same way for both exposed and not exposed? Secondary guides. How much was the attrition or the patient's loss to follow-up? And are there confounders that the investigator failed to address? Then what were the results? How strong is the association between exposure and outcome? And how precise is the estimates of the risk? And will the results help me? Are the results applicable to my population? What is the magnitude of the risk? And should I attempt to stop the exposure? Thank you.